So, what is operative treatment for fractures? Now, having heard about the management of fractures by conservative measures like application of plaster of Paris, traction, slings, etc. Very often now most of the fractures are being treated the sole purpose of making the person to start using their limbs at the earliest opportunity, because all said and done, even though the nature takes care of a fracture and the fracture may get united well by conservative measures, it has got its own limitations like stiffness and then what is known as fracture disease, wherein the bones become brittle or osteoporotic, joints become stiff and sometimes prolonged immobilization, and then or lying down in bed may cause so many complications like respiratory problems, urinary problems and pressure sores, etc. In view of all these problems, now mandatory to fix the fractures wherever you are forced to make the patient lie down for a very long time, or patient wants to go back to work at the earliest opportunity. In this brief introduction about why we are going to operate on a patient, let us see what are the situations where you have got to operate on a patient. First and the foremost thing is failure of conservative management. As already mentioned, sometimes we may not be able to keep the fragments in position, or even if you keep the fragments in position, they are likely to be re-displaced. So, we call first thing is failure of conservative management. Second, the fractures involving the joint. Third, badly displaced fractures. Then multiple fractures. 5, compound fractures. So, these are all some of the things where it becomes almost mandatory or very, very important to subject the patient for surgery. One is failure of conservative treatment, fractures involving joints, badly displaced fractures, multiple fractures and compound fractures. Of course, there are other indications are complications of fractures like delayed union, non-union, etc. Now, basically we can divide these things into the operative treatment can be managed, operative treatment can be broadly classified into manipulative, reduction and POP. The simplest operative procedure wherein we try to put back the fragments in position, then apply the plaster of Paris. Second is broadly open reduction and internal fixation. Here, as the name indicates, we try to manipulate the fragments in the position, then apply the POP. And again, as it is self-explanatory, in the second instance, we try to open the fractures, put them back in position, which is known as open reduction. Naturally, when these two things, for example, these are gone like this, to put them back, you have got to keep them in position. So, from the position like this, we put them back into position, and then you got to keep them in position. That retaining, we will be doing internal fixation. Then broad category third or broad category 3 is external fixation. Here, as the name suggests, suppose there is a fracture here, we do not actually open the fracture. This is the skin. What we do here is, we with the pins through the skin, through the bone, like this. All these things, 6 you can see here, pins are there. These pins are fixed in a external rod. Various things are there in this. We try to fix them up in the external rod. Here, as the lines indicate, the black is the bone which is broken, and the blue line is the skin. Through the skin, through the bones, all these things are brought together and then fixed on some kind of a frame or rod, whatever it is. They are operative management of plaster of Paris, of fractures. 1 with plaster of Paris after putting them in position, 2 open reduction, 3 external fixation. Having said that, let us go to the first one, that is manipulative reduction. Manipulative reduction, as the name suggests, suppose the fragments are displaced here, by using pulling and pushing, traction and counter traction we call it. Traction, that is one side somebody pulls, the other side doing this. With this traction and counter traction, these 2 fragments will come into position. Now, to keep them in position, we apply the plaster of Paris, because as you know, when there is a fracture, there is already a lot of pain. We try to pull and push, that is traction and counter traction. Patient is likely to have more pain and he won't cooperate with you. So, for this you require general anesthesia or deep sedation. General anesthesia or sedation, deep sedation. Now, having said that, once you apply the plaster of Paris, you must know how long plaster of Paris is to be applied, how long it is to be kept, and when we can make the patient use the limbs and all that. That depends upon the type of fracture we deal with and whether it is upper limb or lower limb. When we talk about the individual fractures, we will know more about the details of how to immobilize, how long to immobilize, and then up to what length, that is the duration of immobilization. All these things will be discussed at the time of talking about individual fractures. When we operate, it is common example is fracture neck of femur. There is a fracture here, it is very common, especially in elderly patients, and because the entire thing is encapsulated, that is, a capsule will be there like this. This is the margin known as acetabular cavity. entire thing is inside a capsule. And another problem with this is the blood vessels come from here and they go on spreading like this. Here, because these things are not supplied from either side, the blood supply is only from one side. So the chances of union are very remote. That's why we always try to fix it up. So similarly, when there are, this is known as a segmental fracture. Here also the possibility of union is little remote. That's why you also try to fix it up. And third thing is, sometimes the patients are osteoporotic patients, elderly people. So depending upon where there is fracture, whether in the diaphysis or shaft of the bone or at the ends of the bone, you have got different devices. Then a couple of words about what are the various devices that we use for fixing the fractures. Here there is a fracture. We use what is known as tension band wiring. We use a couple of pins and then a wire will be, stainless steel wire will be brought like this. At the ends these bones are fixed. This is known as tension band wiring. Here, because of the tension of the band, that is the wire, the fragments gets compressed, they get compressed, and because the fracture starts initiating. So here, these are the simplest of all the procedures is tension band wiring. Here only a 18 gauge stainless steel wire is used for fixation. Then one more simple thing for small long bones like metacarpals and phalanges, we use what is known as K wires. Here up to from 0.5 to 2.5 millimeter wires are there. Anyhow, we are going to talk about them when we talk about the individual fractures. Here what we try to do is, there is a small fracture. There is the foot or the metacarpals. What we try to do is put a small wire across like this. This is to prevent the muscles displacing the fractures. However, this normal one may get displaced. Initially it may look like this, after some time it may get displaced like this. So naturally we don't want this to occur, we try to just fix it up with a K wire. This is a simple stainless steel pin actually, but we call it K wire. Then third simplest thing is screws. In this there are different varieties known as cancellous, cortical, cancellous screws, cortical screws, and now of late one more third type has come into existence, that is compression screws. So once again, this is only a broad category, different types we are talking about. The third thing is screws. Then fourth is plates. These plates are made of titanium or stainless steel. Mostly till about a decade ago, we were using only stainless steel. Now, more and more titanium plates are being used. Titanium has got its own lot of advantages. That's why we are using more and more titanium plates. Here, suppose there is a fracture here. We will open the fracture, put the fragments together. A plate is applied like this, and across the plate, these are known as plates. Here, it's not just plates are not sufficient. To keep them in position, we use plates and screws. Intramedullary fixation. This, to take the fracture here, the fracture is here. The fixation of the fragments done by putting a nail here. Once again, previously we were using just intramedullary fixation. Now we are using locking nails. That is, suppose there is a fracture here, this nail is supposed to be this is the thickness of the bone, and the nail thickness must be almost equal. If it is not almost equal, what happens? The nail itself will start rotating inside and it goes on moving, allowing the fracture to move and not getting proper immobilization. So to avoid that, what we try to do is, again we put a screw here, through the skin, through the bone, through the rod, again to the outside. So by this way, what we can do is, here there is another screw, this also is another screw. So here, what we are trying to do is, we are locking the nail inside the bone itself. So it is known as interlocking nail. So these are some of the examples of different kinds of internal fixation. Now a little more development in this internal fixation is locking compression plates. Just like the plates I told you, this is a bone, the plate is here, this is the plate, this is the fracture. So sometimes what happens, especially in elderly patients with brittle bone, the screws themselves, they try to migrate a little bit, causing problems. So to prevent that, we are now, the screws that we are going to apply, we lock them inside in a particular position. The screw doesn't migrate, it gets fixed. So these things are nowadays being used for some of the osteoporotic, that is brittle bone, and in cases where there is extensive damage, so many bone fragments are there, we don't want to open the entire thing. We just push the bone plate under the skin and push it up, then we fix it up. So these are known as, these are all advances that have taken place of late. Now we are making use of those things known as locking compression plates. These are known as locking compression plates. The idea is this, we won't allow the screws to migrate. That is the main purpose of this locking compression plate. Now, I have heard about different types of internal fixation, because it is very difficult to give all the examples, because for every given situation there are different types of devices that are available now. So I have only given a broad hint about various types that are available. Having heard about that, now we will talk about external fixation or external fixators. In external fixators, commonest thing that we use now is usually we use it for, is most often used for tibia, that is the leg bone. Especially this leg bone is more vulnerable for direct injuries or compound fractures, where the skin is lost sometimes or there is irregular skin laceration and there will be a lot of contamination because these things occur either due to road traffic accidents or industrial accidents. So here what happens, we can't get immediate skin cover sometimes. Patient may be having loss of skin cover and sometimes there will be other associated injuries also. So temporarily we have got to keep the bone in position. Here we don't open the bone at all, we try to insert pins. Usually there may not be a straightforward fracture, it may be a little bit oblique also. Here again we keep, as all the pins come out, a rod is passed through and through like this, and these have got clamps like this with holes here through which the rods are passed, and then there is a clamp here which can be tightened. So by using those clamps, these clamps are used so that the main purpose is to secure fixation of the bones. The advantage of this external fixator is to see that the bones do not move. And second thing is, olden days people used to apply plaster of Paris, and then on that every time we used to cut the plaster, open, dress the wound, again do it. It used to be a very cumbersome, painful procedure for the patient. So to avoid that, we use this external fixator, because in between there is a lot of gap. We can easily do dressing of the wound and know whether there is an infection, or everything can be watched about the progress of the wound, and with the help of plastic surgeon we can easily get an easy skin cover also. So that is the advantage of this external fixator. In that there are so many uniaxial, polyaxial and all that are there. So once again, these are all advanced techniques of fixation. At least one must know that there are what are known as external fixators for compound fractures. Now another thing is a Russian by name Elizarov. This gentleman has shown that most of the fractures can be managed by external fixators. And actually long back, nearly 30 years ago, when he came to India, he has shown us pictures where a patient broke both his thigh bones and he has fixed them with this Elizarov external fixator, or it is known as ring fixator. The advantage is it has got such a nice mechanism, you can adjust the fragments and make them migrate upwards, downwards or any direction you want by adjusting the screws and the things which are available. It will be more like this is the bone, suppose there is a fracture somewhere here. What he does is he applies cross pins like this, and this is fixed, and again these rings are with mechanism which includes can be fixed in this mechanism on either side by putting the rods. And just like any jockey that we use for lifting the car, by adjusting the screws that are available here, we can gradually either lengthen it or keep it in position. If necessary, we can change the angle also. So these are the advantages. Once you fix it up with tight springs, they act like springs. These wires will be there inside and they are fixed in this frame. This is a frame into which the things are fixed. Once it is fixed, it will not be moving, and the advantage is immediately the patient can start walking. So that's the main advantage with which about 2 decades ago or 3 decades ago, when it was introduced, practically everyone is trying to do that. But it's got its own disadvantage, like because a lot of wires are applied, then there is a possibility of infection, then it's a big huge frame will be there, people will have to move about with the frames which are outside, and unless you have very loose dress and all that, it's very difficult to move about. Main problem is to keep proper position, and then because it takes nearly 2 months or 3 months for the fracture to unite, to keep a huge frame like that and move about is to become very difficult. But still, even now, for certain purposes and certain chosen fractures, we can still use this external fixators. So to try to summarize the entire thing, first thing is, whenever there is a fracture, you give the immobilization, temporary immobilization, then treat it by plaster of Paris immobilization or use traction, splints, etc. So if it is not possible to keep them in position, then we think about operative treatment. In operative treatment, we have got different metallic things. Usually special type of stainless steel is used for this implant. We call them as implants. But under certain circumstances, we have got the devices in which we don't operate internally, but we try to fix the thing externally. So by whatever method that suits the particular type of fracture and the patient and comorbid conditions, we manage the fractures as required.